Okay. Okay, so welcome back, everyone. So we are joined now by Dr. Amit Patel. He's going to introduce himself, and he's going to talk about CAR T cell therapies, and especially with the highlights from EHA. So as usual, you can ask your questions in the chat or in the Q&A function, and we can ask all those questions at the end to Dr. Patel. And with that, the floor is yours.
Thank you. My name's Amit Patel. I'm a consultant in cellular therapies and transplantation at the Christie in Manchester in the UK, and I lead the CAR T program in the institution. I'm going to spend the next few moments really just talking about CAR T and cellular therapy options for patients with acute leukemia, and particularly touching on highlights from EHA. My disclosures are shown on this slide, and the outline for the talk is shown here. So I'm going to start really with just giving a background of CAR T therapies before we talk about specific products, and then talk about lots of exciting new concepts and research from EHA, both for autologous CD19 directed therapy for BALL, dual approaches, and also just say a few words at the end about possible approaches for AML, although these were not specifically addressed at the EHA meeting. So the reason there's so much excitement about CAR T therapy is that it takes the specificity found on antibody-based treatments and it combines it with the cytotoxicity of a T cell receptor. And so you get this chimeric antigen receptor, or CAR, and because it's in a T cell, it's a CAR T cell construct. So the short variable fragment chain here shown here, which is similar to what's used on an antibody to bind to an extracellular protein on the surface of a cancer cell, is then combined with the transmembrane receptor and the intracellular receptor, which essentially is used to tell the CAR T cell to become activated when the binding part of this receptor comes into contact with the target of interest. On the right-hand side, if we take CD19 as an example, and this is an extracellular, so this is a protein on the cell surface of cancer cells, B-cell malignancies, so B-cell ALL in particular. When the CAR T cell comes into contact with this, just that interaction alone allows the signal to fully activate that CAR T cell. So normally you need 2 signals to activate a non-modified T cell, and often cancer cells inhibit the second signal. So the CAR T cell has both signals. It has CD3 zeta and either 4-1BB or CD28. But the important information here is that it's got the both signals together in tandem, and that then means you don't need a second activation step, and that often is inhibited by cancer cells. And if you think about where they fit into the treatment landscape, they are formed, they are part of a group of treatments called adoptive cell therapy. And adoptive cell therapy can either be genetically modified, like CAR T cells, or unmodified. And although we're talking about T cells, actually you can have NK cells or invariant NK cells or gamma delta T cells as the starting material. It doesn't really matter. The other reason we get very excited about CAR T cells is that when you compare them to other treatment options we have, so unmodified antibodies, antibody drug conjugates, so for ALL, that would be a drug like inotuzumab, which targets CD22, or bispecific antibodies, so that would be a drug like blinatumomab, which targets CD19. CAR T cells are much more sensitive. You need much lower levels of cell surface protein in order to be recognized and become activated. And so the CAR T cells can then kill the target cell of interest. Genetically modified T cell receptors are also going to be coming into the clinic. They're currently in clinical trials, and they probably have the most sensitive receptor in terms of the target and the amount of target that cancer cell expresses. So if we look at potential targets then for lymphoid malignancies, B-cell cancers, CD19 is probably the best target, not just for B-cell leukemias, but also for leukemia lymphomas. CD22 and CD20 are also good targets, but probably CD19 is the best one, as you can see on this diagram, because it's expressed on pretty much all stages of development. And that's why CD19 was chosen, with the first patient with ALL treated in 2013 in the US, with approval in the US within 5 years, and a few years later in Europe and the UK. So CD19, excuse me, is a very good target for CAR T-cell therapy to hone in on. And if we look at this table of approved CAR T-cell therapies currently available somewhere in the world, we can see there's only one that's used to treat B-cell acute lymphoblastic leukemia, and that's actually in children and young adults aged up to the age of 25. So clearly there's a lot of space for development. All the other products are in the mature B-cell cancer space, so lymphoma space, and we can see that in the US there is an emerging treatment for myeloma. The other thing I think it's worth emphasizing is that CAR T-cell therapy, excuse me, is an autologous genetically modified product. So patients that are potentially suitable will have an apheresis procedure. So that means their T-cell, their own cells, will be removed from the blood and then sent to a manufacturing facility for genetic modification. And during that 4 to 6 week time period, patients will then go on to have other treatments to hold their disease prior to the genetically modified cells coming back. The cells will then be infused after lymphodepleting chemotherapy, which invariably includes fludarabine and sometimes, well, usually cyclophosphamide as well. After the infusion, usually in the first month, patients will develop characteristic side effects, including cytokine release syndrome and neurotoxicity, or graft versus host disease if they've had an allogeneic stem cell transplant in the past. And then during long-term follow-up, they will have reduced immune function, and a bit like someone who's had an allogeneic stem cell transplant, they will take some months to perhaps a year or so to develop immune reconstitution and recovery. And in that first month, the reason they get cytokine release syndrome and neurotoxicity is because the CAR T cells that are infused rapidly expand when they come into contact with the target antigen of interest, in this case CD19 on B cell leukemia or lymphoma cells. And then so this occurs in the first week or so, and then during the end of the first week or the beginning of the second week, patients can develop characteristic neurotoxicity. So these are specific side effects related to CAR T therapy, which are manageable, but nonetheless can cause organ failure and a requirement for intensive care unit support. In the longer term, so from the 1 month time point to the 1 year time point, you can see that these patients will develop all manner of infections with low levels of antibodies, low levels of B cells and T cells, low levels of neutrophils and other cell lines, with subsequent late immune effects and secondary malignancies. And this list I'm showing you here is not specific to CAR T cell therapy. You can see a similar list after allogeneic stem cell transplantation. So let's start with what we have. What we have is one product called Tisagen Lecusel, which targets CD19, and it's made from an antibody, a mouse antibody called FMC63. And in fact, all the products that are available or in development targeting CD19 are mouse-derived and have the same target. They have slightly different genetic manipulation, slightly different cell culture and expansion, and slightly different levels of lymphodepleting chemotherapy, but fundamentally they all target the same bit of CD19. And the reason that drug has become available in the UK, Europe, and elsewhere is because in those patients who have relapsed twice with pediatric and young adult ALL, very few patients would expect to have long-term disease control and cure. As you can see here, under 10% of patients would expect to live 5 or more years. And so what we have is anyone who is resistant to first-line treatments, has refractory disease to induction, or has relapsed twice, those patients can then go on to access CAR T therapy as a third-line treatment. And we can see the pivotal clinical trial, the Eliana study, which shows out to 30 months, relapse-free and overall survival that has not been reached. So the median events have not been reached. So at 12 and 18 months, you can see there's a 66% relapse-free survival, and at 2 years, it's 62%. And overall survival at 1 year is 76% and 70% at 18 months. So these are absolutely transformative and massively different to what we used to have before. So at EHA, how can we improve on things, and where is the field going? And I've summarized the abstracts of interest that I've identified here. We're going to talk about children under the age of 3, which were not represented in the Eliana study, but nonetheless now might be treated with Tisacel or Tisagen Lecusel. And then we're going to be looking at axicaptogene silucil, one of the other products. Remember, it's targeting the same bit of CD19. And we're going to look at the data supporting use in children and in young adults, as well as in adults themselves. And also we're going to look at a new product called Obicel or obicaptogene, which is a low toxicity product, which also binds to CD19, but uses a different antibody construct. And then we're going to look at approaches that can be used when autologous CAR T therapies that are currently available or close to approval have failed. And in this case, we can use a humanized form of the target antibody. We can target CD22, which we know is also a good target for B-cell ALL and cancer. And also we can sequentially target CD19 and 22 to make sure that there is no escape mutant, i.e. patients who have their cancer downregulate or lose expression of CD19 on the cell surface, which means that the CAR T cells are no longer able to kill those cells. Or those patients who have constructs constructed with both CD19 and 22 as a target. So one cell versus 2 separate cell populations that are sequentially infused. And then I'm going to talk about donor-derived CD7 targeting for T-cell ALL. And this type of ALL currently doesn't have an available standard of care CAR T option. So this is, I think, quite exciting for the field. So let's start with patients under the age of 3 who were treated with Tisagen Lecusel for B-cell ALL. Now, most of these patients had MLL rearranged B-ALL. 90% of the time product was manufactured, and you can see that the response was an MRD negative complete remission. For most of those patients were infused, and of the infused patients, about a third needed further treatment, of which 1/5 received a second transplant. But nonetheless, I think this study tells us that Tisagen Lecusel, for which we didn't have data from the Eliana study, can be used in very young children under the age of 3, and has a similar relapse-free and overall survival to the Eliana study. The next abstract I want to talk about is the ZUMA-4 abstract. So this is a phase 1 study which presents the long-term outcome data for the patients treated with KTE-X119. So this is the same construct as the axicaptogene silucil product, which again is a mouse-derived antibody targeting CD19, but this is manufactured in a way that it removes the cancer cells from the cells that are collected from the patient. And this is in pediatric and young adolescent patients. You can see that these patients have a slightly higher dose of cyclophosphamide than those patients treated with Tisagen Lecusel. And this was a dose-finding study. So there were 3 dose levels that were used, and those the best dose was then used for the phase 2 follow-on study. And in terms of the study design and the primary outcomes, the outcomes were related to dose-limiting toxicities, and other outcomes were the complete remission and complete remission with incomplete count rate, as well as duration of response, relapse-free survival, and overall survival. The inclusion criteria were patients aged up to the age of 21. So these are younger patients than those treated with Tisagen Lecusel, where the patients were up to the age of 25. They had to have relapsed refractory disease, and the definitions are shown here. And patients with other forms of lymphoma were excluded, and those patients who didn't, those patients who were treated with CD19 targeted therapy, blinatumomab, for example, were excluded. 24 patients received treatment with KTE-X19. And you can see the patient characteristics for the study overall in the 3 dose levels of 2, 1 and 1 times 10 to the 6 cells. What's interesting is that patients who received prior blinatumomab comprised a third, inotuzumab comprised 4%, prior transplantation comprised 25%. So these are quite heavily pretreated patients. And if you look, a third of patients had high grades, so grade 3 is significant cytokine release syndrome, and also grade 3 ICANS, which is neurotoxicity, of 17%. So there was significant toxicity associated with this treatment. And you can see that no patients, however, died of these two complications. In terms of the response, well, the overall response rate was 67%, with most patients achieve it, and those patients achieved a complete remission or complete remission with incomplete count recovery. And 75% of patients achieved an MRD negative response. So very high levels of benefit in a difficult to treat adult population. And we know that adults have typically worse characteristics in terms of disease refractoriness and responsiveness compared to children. And what we can see here in the top left-hand curve is the duration of response at the 3 dose levels, the relapse-free survival in the 3 dose levels, and the overall survival curves here. And what we can see is at the 1 times 10 to the 6 and the 2 times 10 to the 6 dose levels, there was equivalence. Whereas you can see at the 1 times 10 to the 6 dose level in the 40 ml formulation, there was a difference. So here, the 1 times 10 to the 6 dose level was probably the best dose to take forward for the phase 2 study. We can also see in terms of the expansion of the CAR T cells, that seems to be better in those patients who have slightly higher doses. And you can see that again here for the peak expansion. And then in terms of response, we can see that those patients who are responders compared to non-responders had higher peak expansion of the CAR T cells in the patient. Similarly with MRD negative status. And interestingly, there was a trend, but not entirely significant, to higher levels of neurotoxicity and cytokine release syndrome in those patients who had a higher dose expansion. So in other words, some toxicity is to be expected in those patients who achieve the best responses. So what this shows us is that for this product, there is there's feasibility, there's good safety data, and the dose level has been chosen for the follow-on phase 2 study in the teenage and young adult population up to the age of 21, as well as children. The other study using the same product was a phase 2 study called the Zuma 3 study. And what this study did was look at older patients, so adults with B-ALL. And we know from the phase 1 study, which I'll show you in a minute, that the dose level that was had the best responses was again the 1 times 10 to the 6 CAR T cells per kilogram. And the study schema is shown here. The cells are collected from the patient. They receive bridging therapy, then they receive conditioning chemotherapy or lymphodepletion, followed by the KTE-X19 cell infusion. There were 3 dose levels tested, 0.5, 1, and 2 times 10 to the 6 cells per kilogram. And when we look at the overall response rate, actually, this is very high. It's 83% overall, with 65%, so 2/3 of patients achieving a complete response, and 17% of patients achieving a complete response with incomplete count recovery. And then if we look for the dose level of 1 times 10 to the 6 per kilogram, for neurologic events, so grade 3 severity, we can see that after there was some adjustment in terms of treatment, this went down to 11%. And similarly for cytokine release syndrome, this was 33%, so 1/3. So actually, these are probably manageable toxicities. In a paper recently published this month in Blood. If we go back to the abstract that was presented, and the slides show that the primary endpoint for the phase 2 study now was the complete remission rate by central review, with typical secondary endpoints of MRD negativity, duration of response, relapse-free survival, overall survival, and safety. And remember, these patients were adults, 18 years and older, with relapse refractory disease, so more than 5% bone marrow blasts. And in this study, patients could have received prior blinatumomab, i.e. CD19 targeted treatment. Of the 71 patients that received lymphodepletion, 61 received the cell infusion. So you can see that there is a some attrition in patients because these patients are quite difficult to get to a cell infusion just because of the aggressiveness of the disease itself. And this is the diagram I'm showing you from the publication which has just come out ahead of the online, ahead of the print edition in the Lancet. The patient characteristics, we can see the median age was 40. We can see that these patients included Philadelphia chromosome positive, 27%. We can see that half of patients had prior blinatumomab. We can see that nearly a quarter of patients had prior inotuzumab, and almost half of patients has had a prior transplant. So these are very, very, very heavily pretreated, with a median blast proportion of 65% at screening and 60% just prior to starting treatment. Despite that, however, 71% was the complete remission rate, of which 56% was complete remission and 14.5% was complete remission with incomplete count recovery. So these are extremely high response rates, much higher than we can expect with any other therapy that's currently available. And if you look at the subgroups, gender, age, baseline extramedullary disease, CNS disease at screening, prior lines of treatment, and so on, there wasn't really any group that didn't benefit, except one that I'm going to draw your attention to. And that's those patients who had a baseline bone marrow blast proportion of between 75 and 100%. So those patients who had very, very, very high levels of disease just prior to treatment tended to have a less good response. They responded, but it was less good. And therefore, I think this tells us that we need to have more efficacious bridging therapy to try and dose reduce and cytoreduce the amount of disease that's present prior to the cell infusion. If we then look at the duration of response in those patients who were censored at the time of transplant, so in other words, their outcome was paused then, or those who weren't censored at the time of transplant, you can see that there was very little difference that transplant made in terms of overall outcome. And you can see that the median for those patients who achieved a CR or CRI was between 13 and 15 months duration of response for those patients censored at transplant, and those patients who weren't censored at transplant, for those patients who achieved a complete remission, the median had not been reached. For those patients who achieved a complete remission or complete remission with incomplete blood count recovery, the median duration of response was 13 months. So overall, these are quite high responses and good durations of response. This is the similar updated graph shown in the recent publication in the Lancet, which shows a similar trend. In terms of overall survival on the left and relapse-free survival on the right, you can see that for those patients who achieve a response, shown in the purple, achieve a CR or CRI, they have the best outcome with a median overall survival of 18.2 months for all treated patients, and for those in remission, the median survival had not been reached. Sadly, for those patients who do not achieve a complete response, they have a median overall survival of only 2.5 months. And you can see that in the red curve here. For relapse-free survival, you can see for those patients who achieved a response and then relapsed, the median relapse-free survival was 14.2 months. For all patients, it was 11.6 months. And again, for those patients who did not respond, sadly, those patients would not be classified as having any median progression-free survival advantage. These are the updated data that were published in the Lancet, and you can see again a very similar trend for median-free survival on this diagram on the left, and for overall survival on the right. In terms of adverse events, we can see that these are common adverse events that you might expect. In terms of grade 4 and grade 5, we can see that the bone marrow function is particularly affected. So reduced platelet count, reduced neutrophil count in a quarter of patients. And in terms of specifically looking for cytokine release syndrome and neurotoxicity or ICANS, you can see that 24% of patients develop grade 3 or more severity cytokine release syndrome, and similar rates, 25% for those patients developed grade 3 or more neurotoxic events. And interestingly, tremor and confusional state were probably the most common types of manifestations. Most patients received tocilizumab, which is used to treat cytokine release syndrome. and steroids, which is used to treat both cytokine release syndrome and neurotoxicity. Sadly, one patient did die of neurotoxicity due to brain herniation. Responses were associated with the peak expansion of the cells within the patient. So those who had an ongoing response had the highest peak expansion. Those who had a response but relapsed had the second highest peak expansion, and those who didn't respond had the lowest. In terms of complete responders, those patients had a higher level of cell expansion compared to those who did not respond. Similar trends for MRD negativity versus positivity. And now similar trends for those patients who had toxicity with cytokine release syndrome and neurotoxicity at higher grades. So in other words, the toxicity is associated with the response. And these are updated diagrams showing the same trend for response for those patients who have an ongoing response, response for those patients who have a complete response, response for those patients who have an MRD negative response, and those patients who have cytokine release syndrome and neurotoxicity, and the association with high levels of CAR-T expansion in the patient. So I think what we can say really from these data is that at a median follow-up of 16 months, a single infusion is associated with a high initial response and a good duration of response, with really 71% of patients achieving a CR/CRi and more than half of patients achieving a CR. Now, cytokine release syndrome and neurotoxicity, as I showed you, seems to be associated with high levels of CAR-T expansion, and that seems to be associated with response. So is there a way that those things can be separated? In other words, you can still get a response, but you can damp down the toxicity in terms of cytokine release syndrome and neurotoxicity. And one way of doing that is being investigated in the ALLCAR19 study using a product called obe-cel or obicaptogene. And what this product does is it uses a binder to CD19, but this binder has an on and off rate, which is quite high. So in other words, it will bind to CD19, kill the cell, and then let go of the CD19 receptor. Whereas you can see here in the green box, FMC63, which is used for the commercially approved CAR products, has a high on rate and an off rate. So in other words, even if the cell has been killed by the CAR T cell, it still holds on to the CD19 receptor, and that causes excessive activation and perhaps excessive toxicity. And that question was being tested in this phase 1 clinical study, where patients received, rather than a single dose of the cell product, had 2 doses with staggered cells. So a lower dose initially, followed by a higher dose, stratified by how much bone marrow disease burden there was. So those patients who had 20% or less had a lower dose compared to those patients who had 20% or more. And of those patients who had a higher cell dose, a higher bone marrow disease burden, they had a lower initial cell dose and a higher second cell dose. If you look at the dose schedule summarized here, that was combined with fludarabine and cyclophosphamide standard lymphodepleting chemotherapy. And there was an abstract summarizing this. This was a poster. And I've combined it with previous data presented recently at the American Scientific Hematology meeting, where now 20% of 20 patients were treated with this disease, and the disease characteristics are shown here. And I draw your attention to the fact that half received inotuzumab, a quarter received blinatumomab, and 3/4 had received two-thirds had received an allogeneic stem cell transplant. So very, very heavily pretreated patients, of which half had more than 50% bone marrow infiltration. Despite that, what you can see on this swimmer's plot is that in the green, those patients who have achieved a complete response, and in the light green triangles, those patients who have ongoing MRD negativity. And so you can see there's long durations of follow-up up to 36 months shown for those patients who either receive CAR-T therapy as a standalone treatment, or CAR-T therapy, which is then used as a bridge to an allogeneic stem cell transplant. There were also some patients who sadly died either of no response, died after an allogeneic stem cell transplant, shown in the red star, or those patients who died sometime later for not related to their disease. And you can see here, despite the 2 different types of manufacturing processes available and used in the study, you can see that the progression-free survival was just greater than 50% at 1 year. So similar to the other clinical trial data I've shown you so far. And in terms of safety, which was the main rationale for doing this type of study, you can see that for cytokine release syndrome, there were no patients who developed grade 3 cytokine release syndrome at all. And there were only 3 of 20 patients who developed cytokine release neurotoxicity of grade 3 or more. So this clearly seems to be a safer product with a similar degree of efficacy and a similar degree of duration of response. But we need longer follow-up to determine that. What about those patients who have received CD19 targeted CAR T therapy using the FMC63 construct, which is mouse-derived? Can you rescue those patients using a humanized target for CD19? Well, this was the question that was asked in this study presented by Liu from a Chinese center. 18 patients were investigated, and you can see that these patients were heavily pre-treated. They'd previously had CAR T therapy, they'd previously had an allogeneic stem cell transplant with various degrees of relapsed and refractory disease status. Despite that, however, in the median age in this group was 19, so there were adults in this group, 8 children and 10 adults, prior treatments. And importantly, those patients who had isolated bone marrow and extramedullary disease were included, as well as those patients who had a TP53 mutation, 2 patients out of the cohort. So what that tells us is that the feasibility of rescuing some patients with a humanized approach is possible. There were very little additional data shown in that abstract. In this abstract, these are patients treated with CD22 targeted CAR T therapy for patients with adult ALL. Median age here was 30, and 19 patients were included. And the results are summarized here. Again, they weren't presented in any other graph form, but it just shows you that the feasibility of using CD22 targeted therapy for rescuing patients or targeting a different cell surface marker in adults with ALL is feasible. And now I'm going to show you data for sequential use of CD19 targeted and then CD22 targeted CAR T therapy in 20 children with relapsed refractory disease based in this study which took place in China. So patients were aged 1 to 18 with the exclusion criteria shown here. And in this study, what we can see is of the 20 patients treated, 90% developed cytokine release syndrome and 15% developed neurotoxicity. And cycle 1 and cycle 2 refers to the fact that cycle 1 is the first infusion of CD19 targeted autologous CAR T therapy with a gap of 1 month or just over 1 month. And then cycle 2 is the second infusion of CD22 targeted autologous CAR T therapy. And so these patients had received 2 types of cellular therapy. And what's important to say is that you can see that the lymphodepletion was only given prior to the first type of CAR T therapy, not the second type of CAR T therapy. Despite that, you can see that the overall response rate was very high, 100% at day 30. And in terms of neurotoxicity, it appeared to be better tolerated from a neurotoxicity perspective with relatively high levels of cytokine release syndrome overall. But in terms of high grades of cytokine release syndrome and neurotoxicity, so grade 3, 4, actually the numbers were very low with no reported cases. And in terms of long-term follow-up, what we can see out to almost 40 months post-infusion is that although patients might achieve a complete response, and you can see the median time was 1 month, but it took a bit longer in some patients. You can see patient 2 here, patient 18 and 19. The duration of response was still limited. 4 patients died, 8 patients relapsed, and 3 patients had antigen loss despite having 2 separate targets for their CAR T therapy. And so I think what this tells us is that although it's feasible, this may not necessarily be the answer in terms of improving outcomes. We know that those patients who have ongoing B-cell aplasia, so in other words, those patients who have no recovery of the immunoglobulins, maintain their response, i.e. don't relapse, if this can be maintained for greater than 1 year, whereas those patients who have recovery of their B cells and therefore their immunoglobulins, within 1 year, most of those patients will relapse. So the 2-year leukemia-free survival we can see was 60%, and the 2-year overall survival for this pediatric group was 80%. So although this was feasible and the toxicity was manageable, you can see that the efficacy still needs to be improved. What about those patients that are treated with dual targeting, CD19 and CD20? And this was tested in this dual targeting approach where they used a T cell receptor complex as well as a CAR T cell complex in a synthetic TCR and antigen receptor construct, which they call STAR. And what's important here is that it targets CD19 and CD20 together. The construct is shown here, and you can see for the STAR, it has the best of both worlds, both of the T cell receptor gene modified constructs and the CAR T cell modified constructs. And protein structure can be multi-chain. It can have more than 50,000 number of surface receptors per cell. It can target a cell surface receptor, and the signaling capacity is shown. So these are this builds on the approach of the other two cellular therapy modifications. In terms of the number of patients treated, this was 10. The median age was 23 up to the age of 55, so children and adults. But actually, the bone marrow blast proportion was low, and the median was 7% up to 53%. It was the range. And all manner of poor risk factors were including patients who had failed CAR-T, failed transplant, had CNS disease, and had a TP53 and pH positive disease. Despite that, the swimmer's plot shows you that at the 1 month time point, most patients achieve an MRD negative complete response. But then they went on, in most cases, to then receive an allogeneic stem cell transplant, shown in the blue. Only one patient had MRD negative response and then disease-free survival, but then sadly died within a year. So this tells us that this is feasible, but again, improvements in efficacy are required if this is going to be taken further in development. And related to efficacy, you can see that the levels of severe toxicity were relatively low, with no grade 3 cytokine release syndrome and 11% grade 3 neurotoxicity. The next abstract I want to discuss is donor-derived CD7 targeted CAR T-cell therapy for T-cell ALL. This is a type of ALL that we have no CAR T therapy currently available. And this was conducted at the Beijing Hospital in China. We know that up to a third of patients will have relapse refractory T-cell ALL. It's very difficult to treat, and we can't use the patient's own T cells because they're the ones that are malignant, and therefore it wouldn't really be feasible to generate an effective CAR T-cell product. So we can use donor cells as the starting material. And when that's used in the animal setting, what we can see is significant reductions in cell counts in those patients who have received the CAR construct against CD7. And that's also shown here in those patients who were treated with the CAR product versus those patients who weren't treated. This was a phase 1 3x3 study assessing safety of this cell therapy, and the schema is shown here. In terms of the number of patients enrolled, it was 20. The median age was 11, but again, adults were included, so the range was up to 43 years of age. And there were various donors used. A new donor was used, or the prior donor if the patient had had a previous allogeneic stem cell transplant. But again, you can see these were very heavily pretreated relapse refractory patients, although you can argue the median bone marrow blast proportion was relatively low, between 2.7 and 10.1%. From a safety perspective, you can see that grade 3 cytokine release syndrome was highest in those patients who had a prior allogeneic stem cell transplant when the donor was used at the middle cell dose. Similarly, higher rates for graft versus host disease, but no real signal of a difference for neurotoxicity. Infection was an issue, including with cytomegalovirus and Epstein-Barr virus reactivation, which again isn't surprising because most patients were in the post-allogeneic stem cell transplant setting. In terms of low blood counts, this was quite significant. So 90% neutropenia, 80% leukopenia, 65% thrombocytopenia, and 85% lymphopenia. So significant severe bone marrow suppression using this approach. And in terms of efficacy, in the light green here, you can see patients who achieved a complete remission with MRD negativity. And actually, of all the donor types, that was the main outcome seen. In those where a new donor was used, as soon as the patient achieved a response, that was everybody except for patient 6 here, those patients then went on to receive an allogeneic stem cell transplant. CAR T-cell expansion, we can see for these patients at all of the dose levels, depending, and all of the donors was pretty high and consistent out to 270 days. And in terms of T-cell aplasia, you can see that T-cells became absent within a month. And that was associated with expansion of the donor-derived CD7 targeted T-cells remaining at high levels for up to 270 days. So I think this is a feasible and clearly beneficial approach for treating patients with relapsed refractory T-ALL. What about AML? I've talked a lot about ALL so far. What can we do for AML? Well, the problem with AML is that there isn't really a good target like CD19 for ALL. There are lots of different targets, and as soon as you inhibit one target, there are other pathways which then can become more dominant. So what we need is a T-cell receptor gene-modified approach, and that's because this is more sensitive than CAR T therapy, and there is an unlimited number of potential targets that can be recognized by a gene-modified T-cell receptor, whereas with CAR T therapy, although this is highly effective, you need really a single target which is expressed on the cell surface. These data are from ASH. These weren't presented at EHA, but I think they make the point. If you use a CRISPR-Cas9 based gene editing approach targeting Wilms tumor 1, which is typically highly overexpressed in patients with acute myeloid leukemia and some patients with acute lymphoid leukemia, and then use that as your target for a phase 1 study, you can then test whether this approach is able to A, treat patients with relapsed refractory or primary refractory disease, and B, convert patients with MRD positivity with some chemotherapy refractoriness into an MRD negativity. And this is going to be the subject of a clinical trial that will be opening in the UK in the near future. The second approach is to use gamma delta T cells from an allogeneic donor and use these to directly kill AML cells. Actually, it will kill other myeloid cells as well, where there is a high level of immune injury with high level of clonal expansion. These infused cells would also be expected to enhance the immune suppression of the endogenous immune system in the context of somebody who's got AML or a myeloid cancer. And this has been tested in the ACHIEVE trial, which will be opening in the UK in the coming months. And this will allow patients with relapsed refractory AML, those with MRD positive AML, and also those patients who have myelodysplastic syndrome and other myeloid cancers to be included as well. And the schema will be lymphodepletion with fludarabine and cyclophosphamide with enhancement with low-dose radiotherapy, followed by the cell infusion and follow-up. I'm going to stop there and take any questions if there are any.
Thank you very much, Dr. Patel. So there were no questions, and I have to say I don't have any questions because for me it's a lot of information to digest, so it might come actually a bit later. So I guess, well, maybe it's the same for our participants as well. But thank you very much for giving us this talk and explaining more about CAR T in general. That's pretty technical, I would say. but seems to be very promising, at least for patients. So
yeah, I think I appreciate that CAR T therapy by definition is quite a technical
yeah,
treatment modality. It's it's a fairly complicated process. But I suppose the headlines I would say are that we have for ALL got CAR T therapy for patients up to the age of 25, and we are expecting to have CAR T therapy for patients that are adults with ALL who currently have a significant high unmet patient need in the
yeah,
third line setting or the refractory setting in the first line setting. But there are ongoing studies looking at second line and frontline CAR T therapy in very high risk patients for ALL. For AML, where progress has been lacking so far, I think what's clear is that there are now new cell therapy approaches, perhaps not CAR T, but other gene modified or unmodified approaches, which use the intrinsic biology where there are multiple overlapping pathways. So rather than targeting one pathway, using it to target multiple pathways simultaneously. And I think that they're very exciting and I think are going to completely transform the landscape for patients with AML, because at present, if patients with relapsed refractory disease cannot achieve a remission, they can't achieve consolidation allogeneic stem cell transplant, so don't have any long-term disease control prospects. Most patients with AML are older and therefore are not suitable for allogeneic stem cell transplant and therefore don't have a prospect of long-term disease control. And I think what we want to see with these cell therapies in development is that long-term disease control without transplant consolidation. Clearly, patients who can be consolidated with transplant can do, but most patients with AML, as we know, cannot be consolidated with an allogeneic stem cell transplant. And therefore, these therapies, I think, are going to be a new source of hope and perhaps the standard of care going forward if there is efficacy demonstrated.
yeah. Right, so we have one question coming, and the question is about if you know if there are any good prognosis for patient with CMLL.
Yeah.
CMML,
So for
yes.
patients with chronic myelomonocytic leukemia, the study I showed at the very end, the ACHIEVE study, which will be recruiting in the UK shortly, will allow patients with CMML or chronic myelomonocytic leukemia to be included. So those patients can be treated with a cellular therapy. And I think, but don't quote me on this, that study will either be the only one in the world which will allow that patient group, or one of a very small number which will allow that patient group.
Okay, thanks a lot. Great. So, well, if there are no more questions, I guess we can wrap up and give you some evening back for you after this long day of clinic. So thank you very much for giving your time today. Very much appreciated. And again, for the presentation as well, which was very insightful, I would say. If there are any questions coming in the next days, I will take the freedom to email that to you. And as usual, I will post the recording of the presentation, and if you can share your presentation with me, I will also post that on the website and on Facebook and other social medias that we have. And yeah, I'm just wishing you a very nice evening, and thanks again for being with us tonight. Very appreciated.
Thank you, Samantha. I've seen Marula has asked a question.
Yes.
This treatment is a type of transplant. Is that talking about the cell therapy for AML, or I'm not sure, but I suppose for the cell therapy for AML, it is not a transplant. That is standalone cellular therapy, and those cells will not expect to last forever in the patient as treated, whereas a transplant, the cells would by definition be expected to last forever.
Great. So another thank you for me. And
Thank you very much.
yeah, and everyone have a nice evening. And again, thanks, Dr. Patel, for being with us.
Thank you.
Take
Bye.
care. Bye-bye.